Good morning. This is Alfred Sanchez, President and CEO of the Greater Miami Chamber. I want to welcome all of you with us today, attending our next webinar in a series of 3 parts. The second being on children. This is about navigating COVID-19. Today's program is produced by the Chamber's Healthcare Committee that's led by Dr. Brian Stewart, who is the president of the Miami-Dade College Medical Campus and FIU's CEO of their healthcare network, Dr. Eneida Roldan. Dr. Stewart unfortunately had an untimely death in his family this week, and understandably, he can't be here with us today. I know all our prayers and thoughts are going out to him and his family. But we're very lucky today to have with us Dr. Roldan. Anita, I want to thank you so much for your tremendous leadership and the engagement that you have poured into this chamber. We're very lucky to have you. Let me also recognize our media sponsor, South Florida Hospital News and Healthcare Report, and give special thanks to their publisher, Charles Felix, who's been a tremendous partner with the chamber and especially with our healthcare committee for many, many years. He's a huge promoter of our healthcare heroes, and we're really glad to have him with us today. We have, as you could see, a very impressive lineup of experts today to cover such topics as, school policy, the impact the pandemic has had on schools and school learning, the children, the families. We're probably going to cover expanded vaccine authorization that now goes down to children as young as 5 years old. And we want to hear what's happening on the front lines in terms of hospitalizations and the changing profile of the patients that we're actually seeing. Vaccine safety and its different treatments and the therapeutics that are out there now. We want to hear about that. And of course, as if this wasn't all enough, we're about to start flu season. So what's up with that, right? And how does that all interact together? Before I turn it over to Dr. Roldan, let me remind everyone of how we run our sessions. Our microphones are muted. However, you see that the chat box is open. We really want to welcome you and encourage you to network with each other through there, exchange ideas, share information, and keep an eye out because we'll be dropping important links and information in there as well for you. We've learned something through this past year and a half is the importance of healthcare and how important that is to our community. But we who run businesses, especially small businesses, know that it's one of our fastest growing line items. And when we're trying to be budget conscious, especially in years like this, many small businesses are foregoing or feel like they can't offer healthcare. So the Chamber's been working on this issue for the last 3 years, wanting to do something to make healthcare affordable to small businesses. And I'm glad to announce that with our partners at AvMed, we started the Greater Health Trust. This is a health insurance program for small businesses that basically allows them to get benefit packages that are about 30% lower than they can find on the open market because we pool the small business groups and we are able to get big business rates for these insurance. It's a great concept, and we're really reaching out to our members, small business members, to really help them do that. Again, it's the Greater Health Trust, and I think our staff will put a link to that in the chat. And now it's my pleasure to introduce the Vice Chair of our Healthcare Committee, Dr. Eneida Roldan. As I said, she's the CEO of the FIU Healthcare Network. And in addition, she serves as the Dean for the International Affairs for the Herbert Wertheim College of Medicine. She's a media past president and I'm CEO of Jackson Health. She's got extensive medical experience here in Miami, but also all over the globe. We are extremely happy to have her, and we're in great hands with you today. Dr. Roldan, I turn the program over to you.
Thank you so much. Thank you, Alfred, for that kind introduction. It is my distinct pleasure this afternoon to be the moderator of such a timely topic, the impact of COVID in children. Today is part 2 of a series presented by the Greater Miami Chamber of Commerce on navigating COVID. We had an excellent part 1 program a few weeks ago, and I'm sure this program will be just as well received and informative. The pandemic has impacted millions of lives. It has impacted our quality of life, interrupted events, and memories. The impact on our children has been exponential. Their environment has been challenged, with some facing increased poverty, child abuse, domestic violence, and their education process challenged. For many, school is a way to escape the realities they face at home, yet a pandemic interrupted this process. There is no one better that has witnessed these challenges firsthand than the superintendent of Miami-Dade County Public School that leads the 4th largest school district in the US, Alberto Carvalho. Alberto Carvalho has served as superintendent of Miami-Dade County Public Schools, the nation's 4th largest school system since September 2008. He is nationally recognized expert on education transformation, finance, and leadership development. During his tenure, he has become one of the nation's highest performance urban school systems, receiving system-wide accreditation from Advanced Ed in 2014. As an instructional leader at heart, Mr. Carvalho is also the proud father and principal of the award-winning iPreparatory Academy that has become a model of a robust 21st century learning in the age of innovation and technology. Mr. Carvalho will be joining us and will be addressing the challenges facing children, families, and the education system. Welcome, Superintendent. Children comprise 22% of the population. As of September 27th, approximately 14% of all cases of COVID-19 reported to the CDC were among children. Most cases in children are mild, and treatment consists of supportive care. The American Academy of Pediatrics reports children represent 16% of all cases in the 49 states reported by age. Over 5.7 million children have tested positive in the United States since the onset of the pandemic as of September 23rd. Although symptoms are usually mild in children, we have heard and read of children succumbing to this disease. We have seen an increase of cases, especially with the Delta variant. With children back at school, current vaccines only approved for children 12 and older. Cases of myocarditis in vaccinated children, we have all read. So what is a parent to do? To discuss these and other topics of navigating COVID in children, I am joined by my 2 esteemed colleagues, Dr. Mestre and Sanborn. Both Drs. Mestre and Sanborn are at the front line, treating and facing these challenges and anxious parents looking for answers. Dr. Mark Mestre serves as a Vice President and Chief Medical Officer of Nicklaus Children's Hospital. As a board-certified practicing physician in general pediatrics, Dr. Mestre supports the well-being of Nicklaus Children's patients in both administrative and clinical role. He is a fellow of the American Academy of Pediatrics and a clinical assistant professor at the Florida International University, Herbert Wertheim College of Medicine. Dr. Chad Sanborn has been working as a pediatric infectious disease physician in Palm Beach County for more than 10 years, currently with KIDZ Medical Services and Palm Beach Children's Hospital. He treats patients with a wide range of infectious diseases such as MRSA, recurrent fevers, skin and parasitic infections, HIV, recurrent viral infections, and travel medicine patients. Dr. Sanborn is board certified in both pediatric and pediatric infectious disease from the American Board of Pediatrics. In addition, Dr. Sanborn has conducted research in malaria testing in Haiti. So this afternoon, we are joined by an incredible esteemed panel of experts and those that work day in and day out with our children and facing the many challenges that we all have been facing with COVID-19. After the presentations, we will entertain questions, and please do send your questions on chat. And it is now my distinct pleasure to pass the floor to our own Superintendent, Alberto Carvalho. Welcome, Superintendent.
Thank you very much, Dr. Roldan, and to my fellow panelists. Thank you so much for your service, your dedication, and your expert advice to our communities. To my dear friend, Alfred, thank you so much for hosting me once again. We were just together last night at one of your leadership seminars. It's a pleasure to be with you again today. I'll reserve my comments for the procedural steps that we as a school system have taken to protect not only our workforce, but most importantly, our children. We employ about 48,000 individuals, second largest employer in the state, and educate close to 400,000 individuals, 330,000 of them being pre-K through grade 12, the rest adult learners. So going back about 18, 19 months, we can really not believe that's going to be close to 2 years now, when we were forced to pivot our entire educational experience to virtual learning. We did so in a seamless way, empowering our students, obviously, with the devices they needed for connectivity, with virtual content, providing the professional development for our teachers to be able to educate them from a distance. But what we have now learned, now that we have opened our school system, 100% of our schools to 100% of our grades and students, this August 23rd, and we began this school year, obviously we now recognize some of the issues that have ensued since over a year and a half ago. Number one, we've seen a sharp rise in the number of students declaring and experiencing anxiety and stress. We've seen a sharp increase in students reporting some type of abuse, physical or sexual, during the pandemic, during the time that they were isolated from their colleagues, recognizing that often these issues are better recognized in the classroom by teachers, by counselors, school psychologists, or students themselves. And we saw a significant decrease during that time of reporting of those cases. As a school system, obviously, we have invested the right amount of resources in terms of beefing up mental health support, social and emotional support to students as they've returned to the school system, with a huge increase in funding for their services and professionals. Now, the challenge is that everybody's looking for the same professionals across the country. So there is a shortage of professional entities that are much needed right now in our public school systems. One of the biggest challenges we have faced in adopting protective measures and preventive measures for our schools has been some degree of political pushback that is not aligned with the expert advice of medical and public health entities. And quite frankly, that is disheartening and it is of concern to us. We rolled out a series of criteria that we felt were appropriate and were vetted by our medical task force, who relies on, quite frankly, relying on a great deal of information. These individuals are well known in our community. They represent the best of the best in terms of knowledge in issues such as epidemiology, immunology, pediatric medicine. We continue to follow the recommendations of the CDC and the American Academy of Pediatrics, as well as its Florida Association. And we are somewhat baffled by the fact that policies and emergency orders out of Tallahassee are, quite frankly, disconnected from what is widely accepted in the medical community as the best ways of preventing the spread of COVID-19, particularly this more aggressive variant. So when we opened the school system, August 23rd, we opened the school system with the mandatory mask mandate, following an array of procedures in place, such as social distancing, such as intense ionization disinfection of buildings, such as mandatory hand washing cycles, particularly for the younger students, maximizing non-traditional educational space to guarantee a greater separation between the students, allowing students obviously to remove their masks outdoors for athletic activities, PE, recess, etc. And of course, we've been noticed by the state for employing those protective measures because they did not fall in line with some of the emergency orders that basically allow for parents to make decisions regarding masking of their students, and more recently, even allowing parents absolute flexibility on whether or not they should quarantine their students after direct exposure to someone with coronavirus. Obviously, we have unfortunately been put in the position of either embracing and following the wise recommendation of experts or following the political decisions imposed statewide. And in following the expert advice of our task force that is aligned with peer-reviewed research, we have invited, obviously, to a certain extent, legal action and repercussion from the state of Florida. Where we stand today as I close is that we have, on the basis of improved conditions in our community and in our schools, by the way, we're averaging weekly about 3,300 quarantine individuals, the vast majority obviously students. We have had since August 13 about 2,600 individuals, 200 of them employees, the rest students, diagnosed with coronavirus. And as a result, since that time, of significantly improved conditions in our community, we have proposed a list of criteria to be followed to relax the protocols moving forward. I'll close by detailing what those are. Number one, we will revisit the current protocols, which include the mandatory masking and the quarantining of individuals for no less than 5 days. If they are unvaccinated and asymptomatic, they can return to the schoolhouse after the 5th day with a negative PCR test. Moving forward, to further relax the protocols, we're looking for 2 consecutive weeks of a 7-day average of coronavirus 19 cases below 100 per 100,000. As of about a week ago, that was at 333 cases per 100,000, so we're trending in the right direction. Secondly, at least 80% of eligible school-age children, obviously at this point 12 and older, having received at least 1 dose of the vaccine, and 80% fully vaccinated. The numbers right now are at about 75 and 54% respectively. We're looking also as a marker, as a gatekeeper, new daily COVID-related hospital admissions remaining below 100 for 2 consecutive weeks. Next, less than 15% of local hospital beds being occupied by COVID patients. That, I believe, as of a week ago, was around 17%. And then, of course, last but not least, a district-wide new student quarantine due to COVID-19 exposure to school, remaining below 1.5% for 2 consecutive weeks. The average over the past couple of weeks has been around 2%, and that represents about 9,600 students. I'd like to close by simply saying that aside, obviously, from the real tangible physical threat and the political crisis that surrounds what should not be a political issue, should be strictly a health crisis that is dealt with and addressed based on expert advice and the interaction of those who actually master these domains. The biggest concern for us at this point, beyond the physical threat of this virus, is the learning loss that children have experienced. We have seen from last year to this year a compound effect of unfinished learning, followed by the summer slide. And as a result of that, based on preliminary interim assessments, we've seen learning loss as wide as 20%, particularly for the most fragile kids, those in poverty, those who have 1 or more disabilities, and those who are English language learners. And in addition to that, obviously, as I stated earlier, the social emotional impact, the mental anxiety, and the stress that students have reported to us. So those are the conditions we're currently facing as a school system. We have budgeted appropriately to deal with them. We have trained our professionals over the summer to address these issues. And now it's a matter of accelerating each kid towards their full potential.
Thank you so much, Superintendent. Basically, on a personal level, I want to thank you. I want to thank you on behalf of all my colleagues, because this is truly a health impact, and that should be first and foremost. So thank you so much, and thank you for your words. I do have some questions that have come through, if I may. One of the questions, Superintendent, is, as we know, the workforce impact that COVID-19 has done across all industries, because it's not only we are seeing it in the health environment, but also with conditions with teachers maybe not wanting to come back to the classroom, and or illness, because obviously the impact of the illness is an impact of absenteeism. So how is such a large public health district is handling this? Obviously, with what you said, all the students are back pretty much. So how are you handle the challenges of the workforce?
So Dr. Roldan, you're absolutely right. We're facing a crisis across the country in terms of staffing. And by the way, not just teachers. Actually, the teacher workforce is much more stable than other areas of our workforce. We were able to start this school year with fewer vacancies, quite frankly, than we were experiencing pre-pandemic. And I think there are a couple reasons for that. We have an exceedingly high rate of teacher vaccination. So upwards of 87% of our teachers are vaccinated at this point. Secondly, we were able to negotiate very healthy compensation contracts and strict guidelines and protocols for the safety of our workforce in advance of the beginning of the school year. Thirdly, we continue to offer not only free testing, but also free vaccination in partnership with Miami-Dade's health department, University of Miami, and Jackson Health. That brings, quite frankly, the convenience, right, of access to vaccines to the work site on the rotating basis across the district. Where we're seeing significant shortages that are really impacting the quality of service that we can provide are nurses. So we made a commitment years ago to have a medically trained professional in every one of our schools who now are responsible for staffing the isolation room for COVID-19 potential individuals. And we are down about 20 nurses in our school system. And the more we hire, the more then rotate out because of the competitive nature of job offerings in hospitals, clinics, et cetera, across our community. Secondly, bus drivers. Believe it or not, there is a bus driver shortage across the country. We have attempted to remediate that issue by increasing compensation, but it's still a significant challenge. I mean, it merits being said that as a workforce, I have lost 13 of my colleagues, and the vast majority of them were bus drivers, first and foremost, and a handful of teachers. So yes, we are facing challenges, not as severe as other districts that I know of across the country. And I think we benefited from the early negotiation of protocols, the early deployment of resources, testing and vaccination, and also the early negotiation of contracts, which included incentives for vaccination for every single part-time and full-time employee. So when you put those elements together, it puts us in a different position than many other workforce groups, but certainly not at 100% yet.
Understood. Now, always the question of the special needs population, as you know and you well know, we do have a good number of special needs children in our district. So what are the different, what's the environment like in such an impactful, because we do know on the medical side that those would be children that may be impacted and in a much more severe way. And we're going to hear from my two colleagues later on. But what's the environment like for these special need population in the district right now?
So obviously we try to be as inclusive as we possibly can, providing students with disabilities and exposure to an environment that is least restrictive possible. It is the right thing to do. We take pride in the fact that year after year, we increase the percentage of inclusion for our school system. With that said, there are significant challenges, as you correctly mentioned. Number one, students with disabilities were one of three groups of students alongside English language learners and students in poverty, where we saw the biggest decline in academic performance because they were not appropriately benefiting from that personalized attention that is driven by their individual educational plan. It is very difficult to do that virtually. And in as much as you try, you're going to come slightly off the mark. In the school setting right now, the challenges that we are observing, obviously, there are some children with specific disabilities who are not able to wear the mask that is required. Obviously, based on our protocols, we provide for accommodations, and where those accommodations are impossible, then we overprotect the employees who are tasked with teaching them, whether we're talking about teachers, social workers, psychologists, or paraprofessionals that many students require. And if you go into some of these settings where the children, based on their disability, cannot wear protective equipment, then the professionals themselves, quite frankly, look like doctors and nurses in a highly contagious environment with full PPE. Secondly, we have made additional investments to reduce the ratio of professional to children, considering the additional burden and the additional challenge that these kids are facing at this point. But it is absolutely right. This is one of the most fragile student populations, and we are deploying additional resources with additional protection and preventive measures to address the students. One of the areas of shortage, paraprofessionals. We used to have an easy time finding competent, certified paraprofessionals. Requires no more than 2 years of college education to staff our schools. We've seen a significant decline in those numbers because of the labor shortages that we continue to face.
Excellent. As someone who's in education, obviously in higher education, I have a passion for learning. And as you well alluded to, we have also seen an impact, as you well know, in the higher education platform with the pivoting to virtual. I can tell you from the perspective of the medical school, you can only imagine having our students have to leave the hospital because of the number of cases in the hospital and doing a lot of that technology that we should have been doing hands-on on a virtual platform. How do you see, because of those children that have been away, as you will, and a lot of them do not have the access, did not have the access or the IT platform, how will the school be focusing on trying to get them kind of catch up?
Sure.
I know that you kind of alluded to in your presentation, but how will that happen? Is this like school year round?
Yeah.
How will that occur?
Pretty much. I mean, we made a commitment going back to the end of last school year to invest federal stimulus dollars to provide a very robust, actually the longest summer program, more intense summer program that targeted specifically the students we experienced the greatest educational challenges. We have a high level of device deployment, 125,000 devices in the hands of kids. That pretty much covers every single kid who did not have a device, and about 15,000 hotspots for connectivity. What a lot of students, quite frankly, did not benefit from was the appropriate parental support to guide their learning when they were learning online. And therein lied a great deal of disparity in terms of supervision and support for learning at home. And we're seeing the result of that. So our strategy consists basically of a very, very strategic and very long summer school program that concentrated both on academic acceleration, but also arts, music, physical education. Otherwise, you're going to reach a point of academic fatigue if all you do is you address mathematics, language arts, civics, science, etc. For this year, again, on a very targeted approach, we know which students regress the most, and we have a multi-tiered system of support, which includes before and after school tutorial programs, longer school day, longer school year, virtual and one-on-one tutorial services beyond the bell, additional digital content that accelerates and remediates students as well, assignment of these students to lower class sizes for more personalized attention by the teachers. And then, of course, we're already planning for Saturday academies, which began already in some schools, spring break academies for these students, and then again, a robust summer program, which will begin about a week or two after the end of the school year. So for about a year and a half, we will, quite frankly, have the equivalent of close to 2 years of education for targeted students who fell behind. And I believe, I'm very confident that during that time period, we will reach, at the very least, levels of proficiency that will exceed those pre-pandemic. One last point I'd like to make is that, no doubt, many kids have experienced a COVID crisis. But we cannot forget that considering the level of poverty in our community and considering the lack of adequate health care for many kids, early screening, and even food insecurity or home insecurity, we have 9,000 homeless kids in Miami-Dade. That should be the shame of our community, that we have not fully addressed that point. But there are a lot of kids who were in deep crisis before the COVID crisis. Well, those kids have descended into a level of crisis never before seen in our community. That is why the investment of resources support to accelerate them to a new level of normalcy and routine is so critically important.
Absolutely. Agreed 100%. And school is such an important part of that social determinants of what we see in our children. And it is a plan, and we hope, like I said, that we'll see a light at the end of the tunnel very, very soon. Superintendent, last few words that you would like to address before we thank you for your time. I know how busy you are. Like I said, previous to this, lots of us have not had a life for almost now 2 years. So we hope we'll get there. But any last few words for our participants?
Very, very briefly, Dr. Roldan. Number one, let me thank the panelists once again for your dedicated service to our communities. Secondly, I want to express my appreciation to the business community for the support that they have provided in terms of connectivity, in terms of helping us with the distribution of 30 million meals during the pandemic to students, the provision of, in some cases, of free connectivity for kids in crisis. And certainly, I maintain a positive outlook on the basis of significantly improved health conditions in our community. I am proud of the fact that it appears that our levels of vaccination are exceeding those of the state and the nation. That is very good news, but we have to stay the course. And lastly, I certainly hope that this manufactured political crisis that introjects less than informed opinion into what should be solely an educational and a health conversation needs to come to an end. Disinformation and misinformation is hurting our communities, particularly the most vulnerable, and that should not be acceptable, particularly when it comes to vaccinations. I mean, my life is being made more difficult because now people are questioning not only the viability, the effectiveness, the safety of COVID-19 vaccines, but now they're bringing mandatory vaccination that has been widely acceptable across the globe for rubella, for measles, mumps, hepatitis B into question. And that is just insane. So I hope that the medical experts stay the course. I hope that the media continues to do what they have been doing, which is calling out those who engage in disinformation and bringing clarity, reasonableness to the life of routine and normalcy our kids deserve. This is not a crisis of the young. It is a manufactured crisis of the adults that is political in nature and is unacceptable.
So well said. So well said. And you're absolutely right. There is no greater truth than the truth, and through evidence-based. And I can say that on my behalf and behalf of my colleagues, we will continue fighting. We really, we want to thank you. We want to thank you for the great work that you do in our community. On behalf of all the children, every single child is not left uncounted in this county and this district because of you. So thank you so much for joining us, and please stay safe. Thank you.
Thank you.
Thank you. Now we are joined by two of my colleagues. We have Dr. Mestre and we have Dr. Sanborn, who will give us the medical view of what is happening as we navigate and continue to navigate COVID-19, specifically in our childhood population. So I will start. I did introduce them. I will start with my friend, Dr. Mestre. Dr. Mestre?
Thank you, Dr. Roldan, and thank you, Superintendent Carvalho, for all the great work as well. And honored to be here with Dr. Sanborn, just in terms of presenting to you all just the information that, from a medical standpoint, what we're seeing as it relates to COVID-19. So we can go to the first slide here. What I want to do first is present an information just in regards to what we're seeing, number one, on a national level, bring it down to what we're seeing in the state, and then locally here in our area. I'll first start with the Children and COVID-19 State Data Report. This is a report that's put out by the American Academy of Pediatrics and the Children's Hospital Association on a weekly basis. And as you can see, it gets the information from almost every state, in addition to New York City, Washington, D.C., Puerto Rico, and Guam. So we want to present this information to you, and again, so we can filter it down to what we're seeing here locally. Next slide. So this graph is telling. At the beginning of the pandemic, we felt that, well, children aren't affected by this. It is more of a disease of adults. In the fall and winter, we saw that children were being more affected, especially in the northern areas of the country. For us in Miami and South Florida, we did see a peak here last summer, but nowhere near the peak that we saw this past summer. At this highest point in early September, we saw nearly 250 or over 250,000 children being infected with the virus, which was unheard of before. Next slide. And because of this, as you can it's a pure numbers game. Because of this, more children were being affected as a percentage. At the beginning of the pandemic, we see here it was only 2.6% of the cases were in children. And now in the most recent report, 26.7% of the cases are in children. That's multifactorial, related to the adults being able to be vaccinated and hence being protected to a certain extent, and those children 12 and under that cannot be vaccinated and hence are at higher risk for infection. And Dr. Sanborn will be touching base on the vaccines for children. Next slide. And the areas that were more affected than others, at least from what we're seeing now, is here in the South. I know we don't like to call South Florida the South, but we're considered the South as it relates to this area. At one point in the time of August, and I'll share our hospital data here at Nicklaus Children's. Nicklaus Children's had the fourth most patients with COVID during a week time span across the country. So we're seeing that now translate to areas in Kentucky, Tennessee, South Carolina was feeling the peak. We're thankfully getting better from that peak, as you can see from some of this data and other data we'll share later on. Next slide. And this just kind of goes down into what we're seeing in terms of hospitalizations. Not every state reports hospitalization. This report only has 24 states. So you can estimate probably double in terms of the hospitalizations that we're seeing in children. So about 40 to 45,000 children have been hospitalized. And the one thing I do want to make sure I never want to create panic, and most children that have COVID end up doing very well, but there is a certain percentage, about 1% of children are going to require hospitalization and treatment that they have to stay overnight within a hospital. Next slide. And this further goes out in terms of what we're seeing in terms of the hospitalized children across the country. As you can see, we've hit our peak, especially what we're seeing here in the South. We'll see what happens in the fall and winter time. But at its peak, we saw over 1,600 patients hospitalized, 1,600 pediatric patients hospitalized at one time across the country. Again, higher than any time that we had seen during the pandemic. Next slide. And this is what we're seeing in Florida. Thankfully, we're coming down in terms of our cases and hospitalizations that we're seeing across the state. At one point, there was 229 children hospitalized across the state, but thankfully, we're seeing this coming down.
The Catholic Mass will be held in the chapel for patients, families, and staff at 12:30 p.m. today. Thank you.
Sorry about that. And now that's been coming down, and we see that it's improving here. Other areas of the state do seem to have still a higher rate. In Tampa, Jacksonville, still seeing higher rates than we're seeing here in South Florida. Next slide. And this just kind of goes to the point we're just making, continued decrease in hospitalizations across the state. Next slide. And this something again, not to create panic, but one of the things we do worry about, and what we've seen more so during the Delta variant, is children unfortunately dying from COVID-19 infections. Yes, most of these children do have underlying conditions, but there are also healthy children that can be affected. And this 498 number, as I'll show in a later slide, is probably an underestimate because not all states count children in the same way. And for example, in Florida, it's 0 to 14, where in other states, it might be 0 to 20, the span of pediatric patients that we see. Next slide. And as you can see, unfortunately, this has been the September, not being complete yet across the country, has been the highest month of mortalities in children. Again, the risk of mortality in children is very, very low, but it's not to say that children are affected. Any death in a child to us is something that is needs to be paid attention to. And at this rate, this is why we are emphasizing things like the vaccine and the measures that limit the spread of COVID infection. Next slide. And finally, who are the children that are highest risk? And this is a website called the COVID Kit Project, and they look at from 0 to 20. And you can see the numbers of deaths that they've seen have recorded is higher, about 670 deaths. And it's at the extremes that we see those that are highest risk. The adolescents are the ones that tend to be obese patients or have some underlying comorbidity, but very, very common to see obese patients have difficulty and act more like adults and hence have a higher mortality. And then in the younger children, in those under a year of age, we do see the COVID infection causing some issues, many times secondary to co-infections. We'll talk about the flu a little bit later on, but also RSV in combination with the COVID infection tends to cause more severe disease. Next slide. And again, this is just to emphasize, again, this is total hospitalizations that we're seeing across the state in terms of Florida. But as you can see, we almost or pretty much came close to doubling our peak that we saw in last July across the state. Next slide. And this finally, we're expecting to see what we call that multi-system inflammatory syndrome. We're already seeing some of those cases here in our hospital. This is the inflammatory syndrome that occurs 2 to 3 weeks or 3 to 4 weeks after a COVID infection, where you have some inflammatory changes across the entire body, essentially, and causes certain symptoms that need to be treated. And as you can see, it lags behind when the COVID infections occur. So we expect to see more of this coming in the fall and winter time. Next slide. And just I'll end up here, just kind of what we're seeing at our hospital. And thankfully, due to the great work that is being done in the public school system and all school systems across the county, we're seeing a decrease, as you can see, on the daily positivity rate. We were up to as high as 15, 16% in August and September, and now down to 4.3%. And we didn't see that uptick that we expected when school started. And thankfully, I think it's partly due to the great work that our school systems has done to keep our kids safe and healthy. And I'll hand it over now to Dr. Sanborn to present his information.
Thank you, Dr. Mestre.
Thank you very much, Dr. Mestre. That was great. Tough act to follow, but I'll talk a little bit about some of the COVID issues, what we see, what we're dealing with patients in the hospital, and when they present to the pediatric offices as well. So talk a lot of information in a period of time, hopefully not too technical, but hopefully if there's any unclear issues, please give comments, questions in the chat. We'd be happy to address those. So again, it's an issue that affects children, maybe not as severe as adults, but as we'll see and talk about, it is much better with all infections in general. Prevention is better than a cure, right? So it's much easier to prevent the infection that you don't get as opposed to treating the infection that you don't have great treatments for just yet. So next slide, please. So as Dr. Mestre has pointed out, we've seen a significant increase in cases in the last 2 to 3 months. Increased visits to the outpatient centers, to urgent centers, to pediatric offices, emergency departments as well. And there's a variety of factors involved. Obviously, Delta variant seems to be a little bit more contagious. I'll talk about that in a moment. We were, reuniting. We had very low numbers in May and June, and people were going to get together again, traveling and so forth. So that seemed to affect perhaps behaviors and infections as well. And in summertime in South Florida is pretty unique, as you all know. It is different than the rest of the country where, it rains a lot more, it's very hot, and a lot of children are indoors doing more indoor things as opposed to winter or late fall when it's a bit cooler. Next slide, please. So it's just a little, I'm a Far Side fan from back in the day, but basically a lot of people have mistrust of us in the medical community. What are we recommending? Are we experimenting on our kids or anything like that? You're doing these crazy studies and what's happening over here. And this is kind of just poking fun at that. Next field. So what kind of kids are high risk? As Dr. Mestre said, it seems to be we're seeing a lot of obese children in the hospital, kids with comorbidities such as diabetes as well. And I agree, the older children seem to be the sicker ones that we'll see, with another peak in the neonates. The small infants seem to get quite ill with this sometimes, right? So having complex medical conditions seems to put you at higher risk. But I do like to stress that there's not one age only that we're seeing this. We're seeing small children in the hospital, school-age kids, teenagers, and even newborn infants sometimes getting quite ill with this virus. So it really doesn't spare anyone in the pediatrics spectrum. That being said, the average child who gets COVID is not going to be as sick or has high risk of going to the hospital or being hospitalized as an adult or a senior citizen with the same illness. But you get enough children infected, and even a small percentage of a large number can become quite significant, as we're seeing in the children's hospitals. Next slide, please. So why is Delta different? It does seem to be around 2 times more contagious than previous variants. Once you get it, it seems to spread through your respiratory cells and kind of gets the jump on your immune system a little bit quicker than some other variants did. It may be more likely to cause hospitalizations. We're still trying to tease out that data because so many more people have had it. We're seeing more hospitalizations as well. So it's hard to actually tease out if it's making you sicker or just more people are getting sick from it and are coming to the hospitals. And then the last part is that it seems to be a little bit more efficient at being spread before you have symptoms. So that's the hard part, right? So obviously, if you feel ill or your family members are ill, you want to keep them away from others. But if you're not sick, you're probably not going to stay as far away from other people. So this virus can be spread before you're ill with it. And that seems to make Delta a little bit unique. Next slide. So what do we do to keep kids safe, especially the ones that are not vaccinated yet? Well, we'll talk about vaccines in a moment, but masks, I do believe, are important in a great way to try to prevent the spread of this virus, and especially in small community settings and indoor settings, etc. Try to form vaccination bubbles. If you know a small child is at risk for severe disease because they have other medical issues, try to get everyone around them vaccinated. This has been done for years with other medical conditions. Try to have lower risk activities if a child is at risk for severe disease, so more outdoor activities, etc. And then, have a good working relationship with your nurses, your nurse practitioners, your pediatricians, right? You want to be able to ask them questions, know what's going on in your particular neighborhood, your community, to see what's the current risk level, and then when to bring them in for a visit or go to an emergency department to get seen. Next slide, please. I also wanted to mention testing is important too. I do encourage families to get their children tested because it's really hard to distinguish COVID from other common childhood viruses that we're seeing because kids are back together. So as of September 21st, there were 14 million children in the United States who had received at least 1 dose of vaccine, which is great. We could do even better, but this is a good start, I suppose, right? And then some data from Florida I saw said 54% of 12 to 19-year-olds had received at least 1 dose, which is good. Not where we want to be, but it's good, So there's only 1 vaccine which is currently approved for use under an emergency use authorization in kids 12 to 15, and that is the Pfizer vaccine. It is fully approved for kids 16 and up, so that's important to remember as well. Pfizer recently submitted data for the age ranges of 5 to 11, so hopefully by the end of the month, we may have a decision whether or not it'll be approved for the smaller school-age children. The dosing, incidentally, is 1/3 of what you would get for an older adolescent or an adult, and adolescents and adults get the same dose. There's trials ongoing for 6-month to 5-year age range as well, and Pfizer says that by the end of the year, they may have data ready for submission, which is great. Moderna has submitted data to the FDA for approval for adolescents as well in the 12 to 17 age range. That is pending a decision by the FDA. And they say they're about 1 to 2 months away from 5 to 11-year age group data submission. Johnson & Johnson, which is a different vaccine than the mRNA vaccines, and many adults have gotten it so far. They do have studies underway in adolescents, but they're a little bit behind Pfizer and Moderna in terms of their closeness to approval. Next slide. So the question, do vaccines work in kids? Why do I have to vaccinate my kid? I get that a lot. As Dr. Mestre pointed out, we certainly are seeing hospitalized children and children who can get quite ill with this virus, So there are some good studies which do prove that vaccines do protect children as well. So unvaccinated children seem to be over 10 times more likely than, sorry, this slide was spelled wrong, I apologize, but than vaccinated children to end up in the hospital. So if you're unvaccinated, 10 times the risk of going to the hospital. And then in states where they don't have high vaccination rates, the lower quartile seems to be 3 to 4 times more likely to have an ED visit or hospitalization than in a state that has higher vaccination rates, the top quartile, if you will. There is concern over myocarditis, in particular with the mRNA vaccines in young children and young adults. That is currently being reported, investigated by the CDC. It does appear that it happens around 12 to anywhere 20, 30 cases per 1 million doses of vaccine given. In terms of getting myocarditis, which is an inflammation of the heart related to COVID itself, and getting the actual infection, that seems to be anywhere from 300 to 400 cases per million. So you're talking about a 37 time higher chance of getting heart inflammation from COVID itself than from a vaccine. So that makes the decision a little bit easier when you're trying to talk to a family. Next slide. Brief talking about the symptoms. This is a little bit older data, but from the CDC, suggesting that kids can get exactly the same symptoms as adults. Now, the wild card with children is that they often present with less symptoms, so it's harder to know when they are infected for the most part. While they can present identically to the adults, you want to make sure testing is vigorous and robust in the childhood age range, so you know who has it and who doesn't, so that would affect community spread. Next slide. So there's 2 flavors of illness, if you will, in children, bad and worse. No, acute COVID and MIS-C. So acute COVID, again, similar to adults, often less severe than their adult counterparts, but similar symptoms. Most hospitalizations seem to occur around 5 to 8 days into the illness, particularly for the older children. So the teenagers is a classic scenario. They'll present to an emergency department after knowing that they're COVID positive or having symptoms for about 4 to 5 days and gradually worsening from there. Something similar to what we're seeing in the adults. The spectrum of illness in children is quite large. Again, it can be from no symptoms at all, mild cold symptoms, bad pneumonia, and unfortunately in certain children, respiratory failure and ultimate demise. So it can be really anything in a child, but they can get quite ill with this. The multisystem inflammatory syndrome in children seems to be a little bit scarier, to be honest with you, in terms of what we're seeing in children. So these are kids who have had COVID before. Many of them have no recollection of having had COVID. The parents didn't even know that they were positive, so they don't necessarily get very sick when they get acute COVID. Anywhere from 2 to 6 weeks afterwards, they get this immune stimulation and their body kind of falls apart, if you will. So multiple organs can be affected, but the most common and most dangerous one seems to be the heart. So, it's a lot of these children end up in the ICU. In some studies, 100% of the kids with MIS-C will go to an intensive care unit setting. So even though these kids do get better, some don't, but the majority do, but they can get quite ill when they are sick with this MIS-C. And it's unique, demographics seems to be trying to get further delineated, but it does seem to affect African American and Latin children at a higher rate, in some studies up to 6 to 8 times more likely to get MIS-C if you're of African American or Latin descent than non-Latin or African American kids, unfortunately, which was obviously significant in our population here in South Florida. Next slide. Monoclonal antibodies, we do have that available. Some people don't know this, but it is available for children. So, some of our recommendations come a little bit after what we're seeing on the ground. So as Dr. Mestre pointed out, here in South Florida or the South, we saw a lot more cases earlier than the rest of the country. So the nationwide recommendations sometimes in this instance may follow after what we're seeing down here. But basically, the official word from the National Institutes of Health and the Infectious Disease Society of America, they don't recommend for or against use of monoclonal antibodies in children. However, it is emergency use authorized in kids 12 and up. We do give it here in most or many of the hospitals here in South Florida, in certain outpatient centers as well. It does seem to be relatively safe in these children, and adults, at least from the data we were able to extrapolate from, decreases hospitalization significantly, anywhere from 50 to 70% less hospitalizations after getting the monoclonal antibody, particularly in the unvaccinated. So it seems to be, hopefully, what we're seeing, effective in children as well. Next slide. Not to bog you down too much information regarding these treatments, but we do have some treatments for acute COVID. Unfortunately, none of them are magic pills. None of them work miraculously. So it is much better to not get the virus than to treat the virus that you're trying to figure out what medicines work best for a different age group for, right? We have an antiviral medication, remdesivir, same as we give for adults. It is FDA approved for kids 12 and up, but I know myself and my colleagues in Miami as well have given it to neonates as well when you have a kid that's quite sick. So with infectious disease input, we'll often give it to smaller children because, well, it's something to do for them, but this will inhibit viral replication, best if given early. Dexamethasone, we've used this for a long time for kids with respiratory illnesses. It does seem to slow some of the immune activation and some of the lung issues that these children will have. There's baricitinib, which is another fancy immune modulating medication. We borrowed from the rheumatologists, and we give it to stop some of this inflammatory cascade that happens in children as well. And then there's another medication, Tocalisimab, which works slightly differently than some of the others, but we'll give it to extremely sick children or children who seem to be progressing rapidly in their illness to try to prevent them from worsening. As you see, for both acute COVID and MISC, it's a multidisciplinary approach. We'll have infectious disease doctors, intensive care doctors, neonatologists, hospitalists, rheumatologists, cardiologists, immunologists, hematologists, all involved in the care of these patients. So it really takes a whole community of physicians and nurses to be able to care for these patients sometimes. Next slide. Treatment for MISC, similarly, these kids get quite sick very quickly. We'll give intravenous immune globulins. So we're kind of giving them a borrowed immune system to help slow their own immune response during this. Again, this is all new to everyone here in the United States and around the world, so we borrow from other conditions. We treat these similarly because it presents similarly to a condition known as Kawasaki disease that we see and we're well versed in the pediatric world. So we'll give medication in the vein, intravenous gamma globulin, which seems to help these kids get better. We give steroids, again, it seems to be with both of these illnesses, when you get very sick, your immune system kind of gets out of control to kind of reduce that inflammation. And then there are some immune modulators, again, borrowed from the rheumatologists who come up with guidelines for this that we will give to kind of shut down this overzealous immune response, which is affecting the heart, the brain, the gastrointestinal tract, etc. So yeah, basically all-out approach to try to get these kids better as quickly as possible. And most of the ones, even though they get quite sick with MISC, do turn around and improve, and often very rapidly. Next slide. There is hope out there on the horizon. There is a vaccine, like I said, that is authorized currently for older children, and hopefully soon will be authorized for younger children. There are 2 vaccines, hopefully soon to be available, and Moderna and Johnson & Johnson when data becomes available. We do have medications that we can give. Number of cases, as Dr. Mestre had pointed out, do seem to be declining here in South Florida and in the country. And, you know, there's some future medications and therapies down the line. Intranasal vaccines, that would be great if we can stop the actual virus from getting into your lungs and causing this problem. Well, maybe that's something, A, more acceptable to families and giving a shot in the arm, but also B, something that may work as well, or hopefully even better at preventing disease in some of these kids and teenagers. And then oral antivirals. If there's a way to be able to treat the medication before you get sick enough to come to a hospital, well, that'd be great. Like I said, the earlier you get this, even if you can't prevent it, the earlier you start treatment for this, the better off the outcome will be expected to be. Next slide. Unanswered questions. Well, I could do 15 slides of this, right? There's a lot of them. Will kids need boosters? Nobody's sure. The hope is maybe not. Kids with more robust immune systems may respond to this better than adults will and may not need a boost, but the data is still out on that. How often will children need to get vaccinated? Again, same thing. We don't know just yet. They're using less dosing or less of a dose for the vaccine in some of the children, so potentially less often frequent dosing as well. Will there be new therapies for children in the future? Well, there's many under development, and probably around 20 or 30 at least that are in development at the moment. When will masks go away? Oh, that's a question for another day. Again, we're like everyone else, we don't like wearing masks all the time. We don't like telling other people to wear masks all the time. So it's not something that we enjoy as well. When will we have long-term safety data and treatment? You know, try not to be snarky about this, but we don't have it yet. A long time hasn't passed, but down the line, hopefully we'll have more data. And when will COVID end? I have no idea. Hopefully soon. We think things are finally maybe starting to get better, but we've been fooled before. And then the last slide, And again, this is just poking fun at ourselves. Again, we are not, try not to be people in an ivory tower dictating mandates to people without knowing what families are going through, what parents and family units are having to deal with. You know, we like to have fun with our kids. We like to not wear a mask and like to be around other people the same as everyone else. We love going on vacations and traveling. It's just that, well, you know, when we see data suggesting that, hey, maybe it's not the safest thing for everyone, we want to share that information with the rest of the world as well. So again, we in the medical profession are people just like everybody else. And sometimes we lose sight of that when we end up in our battles regarding masks, vaccines, and school closures and things like that. But that's pretty much it. Next slide. I just want to say thank you to everyone. And I'll close with basically, you know, be kind to each other. Again, we are in this, it's kind of trite at this point, but we're in this together. We're all trying to give recommendations to keep people well. We don't like taking care of lots of kids in the hospital. We don't like having to see kids that we need to give these treatments to, right? You know, be patient. Science is changing. We try to be as reasonable as we can from the medical profession, but we appreciate everyone's community efforts and the efforts in the schools, in the hospitals, in community outreach, et cetera, to be able to keep our community healthy. So we appreciate everyone and all this together, you know. Thank you.
Well, thank you. Thank you, Dr. Mestre and Sanborn. Thank you for a great presentation. Lots and lots of information. And I do have to say, since you've used some cartoons, you just spoke like a true pediatrician. Be kind to each other. So you can tell the pediatrician in you was there. So thank you again. Lots and lots of questions. I know that the more that we know, the more questions we have. And, but we know that some parents out there have been hesitant themselves to get the vaccine. And obviously you get that question because they feel, and you just heard from the superintendent that this has actually gone into even the vaccines that have been well known and that have been administered to the children for decades. So can both of you, and this is directed to both of you, talk a little bit about the fact that some of those parents and I'm not going to call it off label, I'm going to call it no label at all, maybe using things like hydrochloroquine and ivermectin. And I'm sure that you have received that question. And I know that in the science literature, we've all been bombarded with issues of even the impact of potential licensure loss of doctors, of our colleagues that could be using that or saying that this is the way to cure. And it's very scary. It's very scary. So again, directed to both of you, can you say something about that? And have you received that question?
Yeah, I can start. We definitely received that question, and it's not infrequent that we receive that question. And what I always tell folks is nobody more than us taking care of these children want a magic pill, magic treatment that's going to resolve things right away. And unfortunately, we don't have that yet. And we try, as Dr. Sanborn said, we go by the medical literature and see what's out there. And once that is available and we see that the effects outweigh the risk, the benefits outweigh the risk of a treatment, then yeah, we would recommend it all day. And we'd be preaching it from the mountaintops. But unfortunately, we don't see that. The only effective way to get over this is through the vaccines. One part I didn't mention in my presentation, we've had for the last two and a half months, about 220 children admitted at our hospital. About half of those are between the ages of 12 and 17. And at least here in our hospital, not one of them was vaccinated. Actually, only one of them was vaccinated, and that child was immunosuppressed. And that put that child at risk. And we see frequently the children that, and those under 12 that can't get vaccinated, that the family isn't vaccinated. And even a neonate, as Dr. Sanborn mentioned, those children can get pretty sick. You see the regret in the family for not doing that because they've passed it on to their recently born child. So those are the things that we deal with all the time, and we try to kind of stand the line in terms of recommending only what's been shown to have some benefit.
Absolutely. Dr. Sanborn, anything on the ivermectin or the hydrochloroquine and parents actually saying, can I use it on my child?
Yeah, I get asked that not uncommonly as well. And the answer is no, I don't recommend it. We don't have enough data. As Dr. Mestre said, we try to present as much evidence-based information and follow those guidelines as best possible. It does seem to always strikes me as odd as, we have a fair amount of information on some of these medicines that we're using and vaccines even more so in terms of these ivermectin, hydroxychloroquine, much less information. And I don't know why someone would be okay with that and not okay with a thing where they can actually look themselves and see all the data regarding more tried and true recommendations. It always reminds me of the movie Contagion, which seems like we're living every day sometimes, where forsythia, right? Some made up medication everyone wants, and that seems to be the cure. We're all looking for a miracle pill to make this better, go away, and make you not get sick at all. We don't have that yet. Our best bet is vaccines, and trying to keep our heads about us and using common sense and trying to be cautious when we're moving forward with as much evidence-based information as we can. So, yeah.
Absolutely. As you all know, we have entered the flu season. And we do know that, children back at school and playing with each other and rubbing their noses and so forth. And parents obviously now being faced with the COVID-19. So again, to both of you, what is your advice? Because as we know, and you just alluded to, a lot of these symptoms are overlapping. But we do have respiratory syncytial virus, another type of virus out there. We've got the common cold, we've got the influenza, and then we've got COVID-19. So if you were to now address a whole panel or a whole participants of parents, what would be your advice? How to navigate that, especially in view because you're scared about the COVID-19 impact? You want to start, Dr. Sanborn?
Sure, yeah, I think kids often don't read the textbooks and will often have 2-3 things at the same time, or their illnesses can look identical from different infectious agents, right? So it is quite difficult to distinguish what is COVID in a small child or an older child for that matter from what is respiratory syncytial virus, what is metapneumovirus, some of these more common viruses that we see every year. So, I think in a good way, kids will still get common colds and they won't become very ill from it. That's great, right? But when you can't tell what's a common cold from what is COVID, even from a medical professional standpoint, I think testing becomes very important and trying to know what your child may or may not have, number one. Number two, even more important now than ever before, when your kid's sick, to not send them to school if at all possible. We understand people are working and don't have childcare and it's difficult sometimes, but it's really apparent, very difficult to say that their child does not have COVID. So to send them to school, it's probably just a cold. Well, it may not be, and that may start a trigger of a chain of events, if you will, in a school community. So very difficult, but COVID testing important, and check in with your nurse practitioners, your nurses, your pediatric providers to ask them what their input would be regarding the symptoms and who should get tested, et cetera. But yes, testing does seem to be an important.
So do not wait.
I would not. Yeah.
Do not wait, especially Dr. Mestre, anything you would like to add to that?
No, exactly the same as Dr. Sanborn said, and just the importance of folks getting the flu vaccine. I know we're all surrounding the concept of, and it's great getting folks with the COVID vaccine, but making sure, especially those that can't get the COVID vaccine, make sure that they get the flu vaccine as well. And again, not to take any infection lightly at this point. Yes, your child may be okay, but to Dr. Sanborn's closing, let's be kind to each other. Let's think as a community and not spread this to other folks who then can spread it to somebody who's vulnerable.
Absolutely. So we do have a question. It says, what reliable resources, in parentheses, dashboard, do we have in South Florida for the public to be kept informed about cases, death, beds available, especially as it pertains to pediatrics? Dr. Mestre?
Yeah, so Miami-Dade has a great website, the county, and it's called the Miami-Dade New Normal dashboard. As cases started going up, then it became available again. It had, since cases had slowed down, they hadn't been reporting as often, but towards the end of August, when we were seeing the higher cases, they again started to provide that information. And it provides information in terms of what's going on in terms of the hospitals. We as the hospitals have to report to the county and make sure how many patients are with COVID each day. What's the census at? Again, I feel lucky when you start seeing the comparisons to the adult hospitals, even though they're much better. We're significantly lower than the adult hospitals. But you can also see what's the positivity rate that's going on across the country. How many folks have been vaccinated? So that's a great website that I always recommend. Again, Miami-Dade New Normal Dashboard. You can just search that on any search engine, and that'll come up and provide the information. At the state level, the Florida COVID dashboard and the Florida Department of Health also provides information. And you can even go further into the CDC. CDC tracker can go down into a county level and also see what's going on at your county level as well.
Absolutely. That website actually is through miamidade.gov, and then you can actually have, and you can choose the dashboard from there. As you alluded to, the coronavirus, as well as there's a covidact.org, which has also been supported with the CDC as well. That's a great one that you can actually go and you can actually see it county, down to the county. So it's not only national, state, but also down to the county level. So lots and lots of information there. And yes, that's information that's reported from our hospitals, as well as other outpatient facilities. Just today, as I was actually going into and preparing for this panel, there was one of these news alerts. And as you know, and Dr. Sanborn, I think you alluded to that in your presentation, and Dr. Mestre, that now we're looking at the possibility of approval. And I know that Pfizer went in and set in the emergency authorization approval for children between 5 and 11. And we all know here that we are doing studies I think it's as young as 2 months, and correct me if I'm wrong. So, I mean, there's different studies going on. However, this poll was very interesting because, again, it alluded to parents not being sure. And they had polled the parents, and they had said that in a good number, a lot of these parents are really not considering to vaccinate between the 5 and 11-year-old. And a second part to that question is, as you well know, which has really hit the media very, 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 I mean, like a fireball, is that when the Pfizer vaccine was approved, here comes the cases of myocarditis, right? And the numbers are not there, really. The numbers are so small, but can you kind of put all these together? Because I do get questions here at our vaccination site at FIU of family members or employees that have students, their children 12 and older, and they're afraid. So can you kind of put it into perspective? And you kind of did, but I think it's a message to take home.
Sure, I'll touch on this. On an everyday basis, I'll say of the families I ask, probably on a good day, 50% are willing to vaccinate their 5 to 12-year-olds. And like Dr. Mestre said, almost all of the patients we're seeing in the hospital are unvaccinated teenagers or younger children who can't get the vaccine yet, right? So I can understand, I guess, if someone thinks that a medication or a vaccine is bad for them as an adult, they're certainly not going to give it to their children. So that's one barrier, I suppose. Second one, people just not sure. Hey, I got it myself, but I don't know if my kid needs it. They don't get that sick, and maybe they're not going to benefit as much as I would from the vaccine. Well, we are seeing, and we have seen, and still living through lots of pediatric hospitalizations. And I think people sometimes focus on deaths, which obviously nobody wants to see in adults or children for that matter from COVID. But the process of going through a pediatric hospitalization in the COVID unit, having your kid require oxygen, having a child not being able to be visited by both parents while they're in the hospital being sick, having a teenager for the first time in their life, oh my gosh, am I going to get better from this? And I have to question that. That's awful to see. Nobody wants to see that, right? I don't think people realize what a pediatric hospitalization means. That being said, I think in terms of myocarditis, these are some of the most well-studied, well-publicized in the age of social media vaccines that have ever come out, right? I think people in any part of the country, you name it, can talk about some side effect they heard about in Chechnya from one of the vaccines, right? So I think vaccine side effects get maybe an undue or unfair amount of publicity for every side effect that you hear about. You really don't hear about as many side effects from other vaccines that they exist, right? Number two, I think the data does seem to suggest that you are at much higher risk, up to 37 times higher risk of getting heart inflammation, from COVID itself than from a COVID vaccine. There is some thought, impossible or very difficult to prove, that the children who go on to get MIS-C, this bad cardiac inflammation, they may have been the same ones that got some cardiac inflammation from the vaccine itself. So we're still trying to tease it out, meaning if you get heart inflammation from the vaccine, it's generally pretty mild. Those kids leave the hospital. If they had not gotten the vaccine and had gotten COVID, they may have gotten MIS-C, and that's more of a severe illness. So, there's a few takeaway points. No vaccine is completely without its side effects. No medication is, but I think by and large, we've given this to millions of people so far, and we do see that the overwhelming numbers are very safe for these vaccines.
Absolutely. Dr. Mestre, anything you would like to add on cases of myocarditis and those parents that are fearful, right? They're fearful.
And I understand, again, going back to being kind and understanding and not passing judgment because somebody has that fear. And that's understandable. I have 3 children of my own, and 2 of them were eligible to be vaccinated initially. And my wife and I had that discussion, okay, how do we go about it? And we're in the field. So I understand that. And I think a part of it is education, trying to give them the right information in terms of making the decisions. And it comes down to the benefits, certainly outweigh any of the risk with that. And I think Dr. Sanborn makes a great point. A lot of times we just talk about mortality. That's all you see in the news. There's a lot more to COVID than just the mortality. Long COVID syndrome, having not been in school. We've talked about how important it is to be in school with all the psychological effects it has. So besides all that, the benefits even go higher from that standpoint. So that's why I try to explain it to families and make sure that they take everything into consideration. And again, being part of that community to assist in wiping this out, or at least not making it as an issue as it currently has been over the past year and a half.
Absolutely. Dr. Mestre, you brought up an excellent point. I was going to actually ask that question. One of the things whenever I talk about COVID-19, obviously, and we talk about prevention, and why is it so important about prevention? Well, the idea is not to ever get the disease, right? And that's why really that is our main goal. And one of the things is we have seen in the adults, what's called the post-COVID or the long haul COVID syndrome, right? And we've seen adults that they have had COVID. It may not even have been a mild disease. And then months later, they come in with issues with brain fogginess, with GI symptoms. I'm wondering, are you seeing the same thing in children? Because that's important because children have a much longer life span.
Yeah. Well, definitely we do, just in terms of, especially in our adolescents. We tend to see it more often in the adolescent patients. Again, as you can imagine, school is hard enough being an adolescent teenager as is. Add to that, now they can't concentrate as well. They can't take the SAT, and then it leads to anxiety and more psychological factors. So definitely something that is seen as something that we got to take in consideration when you're saying, okay, what's the benefit of this? It's not just, again, going back to what we said earlier, not just about mortalities, but how does this affect the life of the child?
Absolutely. Dr. Sanborn, have you seen that long haul or the so-called COVID-19 syndrome, post-COVID-19?
Yeah, I even saw a patient this morning with that type of syndrome. So it's challenging. Like Dr. Mestre said, it is more commonly picked up in the adolescents. I do have a hunch that it probably affects younger children as well, just that they're not quite as well versed verbal and describing their symptoms. And for a lot of the kids, this is a community thing. So it's hard to tease out. Is little Joey upset because grandfather passed away for a few months ago from COVID, or because parents out of work, or because they're stressed at home over finances or something like that? Or is it because they are not feeling well because they are still recovering from an infection that they had earlier, right? So yes, it's an issue. We don't have wonderful treatments for that yet either. We're still learning very quickly on the fly to figure out how to best negotiate that. But it is something kind of hidden, if you will, that you don't find in the numbers necessarily. You don't see in mortality data. You don't even see in hospitalization data, but it's real, it exists, and it's impossible to know who it's going to affect until after the fact, right? So it's certainly something we're dealing with and struggling with.
Absolutely. If there's anything to convince any parent or any family member about the use of masks as possibly a prevention and all the preventive measures that we know that we have studied, and then now to vaccinate, is the fact that we need to prevent the post-COVID-19. There's not a lot of talk about that. To your point, we go to the extremes of the mortality, but definitely the long sequelae, which stays with the child and or the adult, is extremely important. So if there's anything that we can push to have people understand how important it is, first prevention, and then obviously through the prevention, the vaccination, that would be one. One final question before we close, and that's the elephant in the room. How do you both see this as being part of your requirement in the future of your required vaccines in childhood and adolescence?
Yeah, I can go first. It may be. Most likely, it may be something more like the flu vaccine, and depending on what we see in the community. I always tell folks that what we know is what we know right now, and that could change. I hate to rush to judgment in terms of saying that this is absolutely something that's going to be needed, and moving forward, depending on what we see, what variants pop up, and how we adapt to it. So that's something that I don't think we know the answer to right now from a policy perspective, and how it would get done and how it's implemented. Then you start talking about those kids that had the infection. Is immunity just as significant or not? So it's not as straightforward an answer as some might like to have it. But definitely we're highly encouraging it. And I always say that folks, that we need to protect ourselves as the adults, and making sure that to make our children safe. I want to have the schools open, and whatever needs to be done to do that from an adult perspective, make sure that we as adults take on that responsibility so we protect our children in our community.
Absolutely. Well said. Dr. Sanborn, any last few words of advice? And I know, always remember, be nice to everyone. That is one take-home message. So any final words on your end before I close?
Yeah, no, I know it sounds simple, but it's true. It'd be nice. The same thing I say to my daughters, right? Be respectful of other people's feelings and what they're going through. And I think, unfortunately, this virus isn't going away. I think it's going to be with us for years, if not forever. I don't think it'll be as impactful in a good way to the world and to the community, right? But I think we have to figure out ways to negotiate living with it, and whether that's periodic vaccines once a year, like a flu shot, as Dr. Mestre pointed out. I think that's a good possibility. Part of routine childhood vaccines, maybe, right? I think this is something unprecedented in terms of, in the age of communication, travel, social media, dealing with a pandemic like this is something we've never seen before. So everything is kind of new. So the things I urge parents and my colleagues in the hospitals and the clinics as well is, patience. There's a lot we have to learn. We, as Dr. Mestre said, we know what we know, sometimes not even that, right? So it's a challenge. Things change. We try to follow the best information, but I do implore people to exercise patience with your neighbor down the street, with the physician you're visiting with getting information from someone you see online, and not just being an internet troll and trying to shame them or something like that. I think there's a lot to be learned from this, from the pediatric patients we deal with, right? To them, they're pretty adaptable. They're kids. Their life is all about change in many respects, right? So we can maybe learn some things from them, but trying to be unified when we move forward as best possible, knowing that there's going to have different opinions, which is good, but trying to be as unified as we can to, as a community, deal with this in the best way possible to have the best possible outcomes.
Absolutely. Well, thank you so much to both of you. And I know the superintendent had to sign off, but we have been very, very fortunate to be able to gather the three of you with such knowledge and such great information of the many questions, right? And many more questions to come. So on behalf of the Greater Miami Chamber of Commerce and the Healthcare Committee, I want to thank you, this esteemed panel, for this great presentation this afternoon, and for everyone that has joined us this afternoon. We have navigated this pandemic in the US since early 2020. The world has been impacted since December 2019. We have come a long way in prevention, screening, testing, treatment, and vaccines. However, more must be done. But today we say science and medicine will continue to fight for the health of populations. We hope very soon to see the light at the end of the tunnel. So stay tuned for part 3 of the series, Navigating COVID, and part 3 will be COVID and the geriatric population. So thank you so much for joining us this afternoon. Thank you, Chad. Thank you, Mark. And thank you, everyone. And please stay safe and get vaccinated. Thank you.
Thank you.